I'll move across to Louis-Philippe for a short didactic talk on how GINA guidance has changed in the last 2-3 years. I mean, we have seen updates almost every year. And so I think for primary care physicians to just keep up with that, what are the key messages in the last 2 years? Louis-Philippe, you have been involved closely with GINA. Over to you.
I wanted to initially just show three slides about what GINA recommends in regard to COVID. And it will reiterate, in fact, what Alan said. I think people with asthma, particularly when they are controlled, do not seem to be at risk of acquiring COVID or having a more severe COVID. It's those with an unstable, uncontrolled asthma or on OCS or oral corticosteroid that are maybe at risk in this case. So I think it's reassuring for everybody. And the implication in regard to asthma management, we said that the major point is to get control, not to lose the control, keeping the good medication that is required and using the ICS, the inhaled corticosteroid when needed. So we see that many studies have shown now that there was a reduction in asthma exacerbation throughout the pandemic, probably because of the measure that were taken, the health measures. In regard to the medication, we said we have to pursue the medication to adapt according to the level of control. All asthmatics should have an action plan on which is written what to do if they worsen. And of course, we have to avoid everything that will increase the risk of spreading the virus, such as nebulizers. And of course, we spoke about spirometry to be careful about that. Of course, once again, GINA suggests that the booster shots should be offered. We suggest, in fact, that if they are on a biologic, for the more severe types of asthma who are on a biologic, that the vaccine should not be given on the same day. It should be, this will allow us to see if there are side effects to this drug or to the vaccine. And of course, influenza should still be given. It will be important to prevent that, even if the rate of influenza is quite lower than it was, probably due to the health measures.
Over to you, Louis-Philippe, for the second case.
Thank you very much. So I'll talk briefly about long COVID, because this is one of the concerns that we all have these days. Let me talk about John. John, in fact, is a 30-year-old man that had moderate atopic asthma since childhood. He had an allergic rhinitis. He has GERD, also gastroesophageal reflux disease, that is treating with the PPI sometimes, but sometimes some other agents. His optimal FEV1 was 82% predicted, so not too bad. His FEV1 over VC usually was around 70, 72. He had a diagnosis proven from bronchodilator response. In this case, he did not need a methacholine or another type of bronchoprovocation test. He was on a moderate dose of ICS to be controlled with formoterol, BID plus PRN, so he was at the marked type of treatment. He was relatively adherent to his treatment, I must say. I always ask the percentage of adherence, and in his case, he said, "Oh, you know, Doc, I'm probably 70% adherent." I said, "Okay, that's probably a bit lower, but okay, I know that." He was well controlled until he was diagnosed with COVID-19. Well, his asthma, in fact, exacerbated. It was a Delta. His asthma exacerbated slightly, but he did not need, in fact, hospital admission. He has increased, in fact, slightly his ICS with some benefit initially, but for the following months, in fact, he had a persistent, troublesome cough, and he was still complaining of dyspnea on mild efforts. He had to stop training. He was unable to keep his usual training at the gym. And he tried to increase his asthma medication, but once again, it had some limited benefit, and he was wondering what was happening there. So the respiratory symptoms were affecting his daily activities and sleep. So this is, I guess, a relatively typical case that we see sometime following COVID. Even if they're not more at risk, of course, some asthmatic can get it. And we have to ask the question, is it really a long COVID that is getting installed? Is it asthma that is difficult to control? is it deconditioning because he stopped doing anything because he was too dyspneic? What about the cough? Is it due to a worsening of his GERD, all the medication that he was taking in fact before, or trying to get rid of his symptom? Were this increasing the GERD problem? Was it due to the COVID or the post-COVID problem, or another cause? So of course we have to look at the differential diagnosis. So of course we said that, first, long COVID is, how long is long? So there are many suggestions. For example, in the Young COVID review in 2021, it's interesting because it showed, in fact, all the criteria that the author chose to decide that it was a long COVID. So it's very variable from an author to another, as you can see. I like, in fact, to look at the UK NICE guideline about that. They said long COVID is referred as a post-COVID condition, post-COVID syndrome, or post-acute sequelae of SARS-CoV-2 infection. So they say it's symptoms that develop during an acute COVID and continue for at least 2 months or 3 months from the onset. They are not explained by an alternative diagnosis. This is why we have to do a differential diagnosis from the start. And what's interesting is that they have 2 types of so-called long COVID. In fact, there is an ongoing symptomatic COVID. It's simply that people have a COVID and the symptoms are still there between 4 and 12 weeks, and they did not resolve. And it's like the acute event is prolonging slightly up to 4 to 12 weeks. And for the NICE guideline, they suggest, in fact, that we can really think or speak about long COVID or post-COVID-19 syndrome if they have more than 12 weeks, symptoms more than 12 weeks after the start of the acute symptoms. But as you can see, once again, there are many opinions about that. And of course, when we see a patient with symptoms like the one I showed, Alan was very right, in fact, telling about different conditions, because it can be a lung problem, it can be the asthma problem, it can be a heart condition, because there are many problems, myocarditis and all sorts of problems following the COVID. They have neurologic problems, sometimes all sorts of other types of problems, even gastrointestinal, and of course blood vessels problem associated with coagulopathy sometimes. And if you look at the mechanisms to explain these side effects, particularly at the level of the lung, what you could see is that there may be, following COVID, a persistent chronic inflammation with production of cytokines and reactive oxygen species that are released continuously into the tissue and the bloodstream. And this may persist for quite a few weeks or months sometimes. They may also have some endothelial damage. It can lead to fibrotic changes in stimulating the activation of fibroblasts and the deposition of collagen. So it's a kind of scar tissue that can lead to a kind of fibrosis of the lung. And of course, there is this endothelial damage that leads to an activation of the coagulation pathways and lead to a prolonged hyperinflammatory and hypercoagulable state, so with potential thromboembolism. So there are all mechanisms that can occur after, in the months after a COVID problem. It was more about the Delta. I don't have many data about the Omicron, if it's as bad as that for this type of problem, but we'll look at it. But the differential diagnosis for dyspnea or an even cough sometimes is not only related to the lung, and we have to look at the different systems that can produce, in fact, these symptoms, as mentioned on this slide here. And psychological are part of it for anxiety, as I mentioned. So Alan showed this slide, and he showed that there was a very mild increase here in potential risk prediction of COVID, long COVID, for asthma and COPD. For asthma, this is for COPD, but the upper one here is for asthma, just at the top here. For asthma, it's almost non-significant. It's mostly for COPD here. And for asthma, if there is a risk prediction, it's mostly for very severe uncontrolled patient on OCS, where they have, we can predict that it may go not as well as we expected. So the symptoms, we spoke about that. It can be fatigue, dyspnea, chest pain, cough. There are so many of those. As I said, there are 200 types of symptoms that have been described for long COVID, but it's mostly, in fact, dyspnea and cough. The other ones, of course, can occur if there is another system affected. And of course, the prolonged symptoms are common even in patients with less severe disease who are never hospitalized. So even if they had a mild COVID, this can lead to prolonged symptoms that can be part of this syndrome or condition. So there are many patterns that have been recognized, of course. For most of the people that have been infected and did not require hospitalization, we almost have no studies on these patients. We don't know exactly what's happening in those. So we need more studies to look at this condition.
Louis-Philippe, just your feel of Omicron. It's just been about 2 months into Omicron, probably in Canada where you practice. Do you think you're seeing long COVID symptoms? Because we are seeing at least 4 weeks plus. We haven't yet reached the 12-week mark, of course. What is your sense?
Oh, absolutely. Yeah, we have Omicron that lead, in fact, to persistent symptoms for quite a few weeks. My prediction is that there should be probably some long COVID with Omicron. As for the Delta, I don't know the proportion, however.
Sure.
We know that with the Delta, it can go up to 30% of those who had a COVID with the Delta. I was trying to get some data from South Africa, where they had Omicron before us. Yeah. It's not sure right now, but I don't see why we should not have a long COVID with Omicron. It should happen, but hopefully it will be less than Delta, but I'm not sure about that.
Great, thank you.
For asthma, in fact, there are studies that have been published on non-COVID in asthma. This is one interesting one by Philip. And if you look at the persistent of breathing problems, this is in fact those who have no long COVID and those who have long COVID. And this is the breathing change from before having COVID-19. And in fact, it's interesting to see that, of course, the much worse than before is a little bit, is longer, is worse than for the non-long COVID. There is a certain degree of severity for if you had a more severe COVID initially. Probably if you had more symptoms, then it's persisting a little bit more. But once again, it's difficult to conclude absolutely between that. The cough is also a symptom that is very common. I was very interested to look at this study by Song that reported acute and persistent cough following COVID, mostly Delta here again. Of course, it's quite variable from a study to another, but interestingly enough, in some groups, in fact, the persistent cough is quite prevalent in regard to the acute one. So it's a symptom that can persist for a long time. And there have been studies on mechanism by which COVID can lead to, in fact, a persistence of cough. And the basic principle is that it's probably affecting the neurologic pathways. It may be influencing cough from an effect on the brain with cytokines or mediators that are affecting the cough centers in the brain, or it can be probably affecting the peripheral nerve, the afferent sensitive nerves. But once again, I think dry cough is one of the most common symptoms of COVID with dyspnea. And of course, the management of this with COVID is really unclear right now. It's difficult to treat that cough sometimes. They are suggesting, in fact, the same approach as for the other refractory cough, even gabapentin sometimes, but once again, we don't know exactly how to treat these cough. As mentioned here, they think it's an invasion of the vagal sensory neurons that bring, in fact, the message of the urge to cough to the brain. So this is really something typical of a long COVID syndrome right now.
We've sometimes used gabapentin, Louis-Philippe. Any precautions that the GP should take when using it? Any advice to the patient?
I think when we are up to gabapentin, it would be better for the patient to be looked by a specialist, because we really have to be sure that it is the case. There are so many other conditions that can be related, can be causing, in fact, a chronic cough. I mean, if you look at the cough guideline, the American College of Chest Physicians, the differential diagnosis of persistent cough, you really have to go through the differential diagnosis. And if it's a refractory, unexplained cough, if you try to find a cause and you don't find a cause, then probably you can go to these medications that are not without side effects. Of course, they have a lot of side effects. So we have to be careful about that.
Yeah, Alan, you'd like to comment on that? Because, it's rare that we've had to go to gabapentin, I must confess, Louis-Philippe, but being a specialist, when you get patients who you've tried anti-reflux, the antibiotics, inhaled steroids, sometimes even a short course of oral prednisolone, we've had to go to gabapentin and very rarely even low-dose short-acting morphine. Alan, your thought?
Well, the way I like to describe it, and for the primary care physicians, it's just like you're treating neuropathic pain.
Right.
And when you treat neuropathic pain, the nervous system actually changes in a process called neuroplasticity. In this situation, the neuroplasticity is affecting both peripheral and central nerves, with central hypersensitivity as well. So the way you would use gabapentin or pregabalin or something is just like you'd approach it with chronic pain, which is start low and go very slow. But again, I think the emphasis on what Louis-Philippe says is make sure you haven't missed something else before you just chase the symptom.
Absolutely. Thank you.
And I think a chronic cough or persistent cough should be treated as any other persistent cough. We have to do the workup. And if I can make a recommendation of an excellent reading, of which Alan is an author also, is there was a guideline published, a state-of-the-art paper in the Canadian Journal of Respiratory and Critical Care Medicine recently by Imran Satia, S-A-T-I-A, as the first author. You'll find everything you need to look at persistent cough in this wonderful paper.
Fantastic. Good message. And we hope everyone who's tuned in will read that. Thank you.
Yeah, you should read that.
Thank you, Louis.
So anyway, this is just in fact a couple of slides to finish on some recommendations that have been proposed for clinical investigation of these post-COVID symptoms that are persisting. This once again is from the NICE, the UK NICE guideline. Of course, full blood count. You never know what you can find. They're doing kidney and liver function tests, C-reactive protein tests. They suggest in fact an exercise tolerant test. During this test, you're measuring, of course, heart rate, breathlessness, and O2 saturation, which is very key, and a chest X-ray, in fact, for all patients that by 12 weeks after the first infection. So I thought it was an interesting first step. The only thing that is missing for me, if you have a patient that had already a respiratory condition, is that I think I would add a pulmonary function test to that. But that's interesting. I think in airways disease, I think we should do this lung function test. And of course, always consider alternative diagnosis. And don't forget, and Alan said that, thromboembolic disease. It's so often that sometimes, where pulmonary embolisms are missed. It's always my nightmare. If there is anything that is wrong or I don't understand, I have to check for that too.
Sure.
So finishing with that, post-COVID evaluation, this is not an easy task. It's always interesting to have a multidisciplinary group, in fact, to look at these patients. And there are many studies done in Canada right now on how to manage these patients the best. And of course, we have to have to speak to the patient to really dig into what he thinks about his condition, to have a goal that is achievable. Most post-COVID conditions can be diagnosed and managed in primary care, but I think we should have the availability of a multidisciplinary care center if it's a bit too complicated or if it does not improve. And of course, we have to avoid excessive testing, as we always say. We tend to do too many tests. I don't think it's everybody that should have a CT scan or another very invasive test, like a bronchoscopy or something else. We have to have clues, in fact, to indicate that there is a need for that. And of course, we should be step by step looking at the different diagnoses. I won't go through that. Sorry. In fact, the last two slides were simply a summary of the NICE guideline. You can have a look at this. This is in fact a a table that reiterates, in fact, what I just told you in regard to the step-by-step management of these patients, up to the management, the follow-up, monitoring, and of course, looking at all the aspects of care and all the aspects of potential diagnosis, as I mentioned, including, in fact, physical, psychological, and psychiatric aspects of rehabilitation of these patients sometimes who are in trouble. So I think I will conclude here saying that I think it's common, the long COVID. It should be distinguished from other conditions that can be treated separately, or like uncontrolled asthma. A systematic evaluation, a step-by-step evaluation should be performed. We should do enough tests, but try to avoid over-testing. So this is not an easy task sometimes. Thank you for
your attention. Fantastic presentation, Louis-Philippe. I think there are so many important messages to clinicians here that don't forget your basics in respiratory medicine when it comes to long COVID. Evaluate the patients just like they would, but a very interesting space in respiratory medicine, which I'm sure we're going to read more about. I liked the fact that you all had a duplicate of those slides actually on the risk factors for long COVID, because they're so important, Subtle features there, I thought, the female aged above 40, which is what we see in clinical practice, and we don't know the reasons why, and maybe it could stem from what Alan said, maybe a little more anxiety, but I don't want to be gender biased here, but we could have so many issues here that contribute, that we'll probably learn more about in the coming months. Thank you so much, Louis.